Hi, welcome everyone to our debate. My name is Ricky, and I currently work as a program director and a speech language pathology assistant at Redlands Community Hospital. We serve children who need speech and occupational therapy services. I have my bachelor's degree in communicative disorders, and I'm working on my master's in this program. And then we have Kelsey, who will tell you a little bit about herself.
I'm Kelsey. I also just recently graduated with my bachelor's in kinesiology. I've been working in the field of ABA for 2 years now and going through this program along with you guys. So this is our debate. We are looking at the alternative models that are used to address the quality of care for children with autism. And in this debate, we're going to specifically look at the ABA model and how it would compare to the medical model and sensory integration model. We're also going to look at any ethical dilemmas that are involved in these models. And our base question is going to be, which model is the best based on research and evidence-based practices to address the quality of care for these children with autism spectrum disorder? So Ricky's going to start off with talking a little bit about the basics of ABA.
So the basics of ABA, let's start with the definition, is an applied natural science that uses the functional relationship between behavior and the environment to systematically improve behavior. The principles of ABA, and I'm sure you guys have all heard this, are applied, which means applied interventions deal with problems of demonstrated social importance. They're behavioral, which is applied interventions deal with measurable behavior and reports that can be validated. They're analytic, which is applied interventions require an objective demonstration that the procedures cause the effect. They're technological, which is applied interventions are described well enough that they can be implemented by anyone with training and resources. They're conceptually systems. Applied interventions arise from a specific and identifiable theoretical base rather than being a set of packages or tricks. Effective, which is applied interventions produce strong socially important effects. And then generalization, which is applied interventions are designed from the outset to operate in new environments and continue after the formal treatment have ended. I kind of want to go over an article that I found that is really good for our class to hear. And it's by Mary Beth Welch, who advocates for applied behavior analysis for children on the autism spectrum disorders. She goes over 10 reasons why children with autism deserve ABA. The first reason is individuals with autism deserve ABA because it can prepare them to be their own advocates. Reason 2 is children with autism someday are going to move on from their parents and become functional communication independent users of whether it's, PECs or anything that can promote their communication and behavior. Reason 3 is children with autism deserve ABA because it can teach parents how to respond in the moment. Reason 4, because it enables their parents and teachers to capitalize on their strengths and preferences. Reason 5, it can teach them skills necessary to make friends. Reason 6, it can be the best defense against low expectations. Sometimes teachers and parents and therapists expect low things from kids with autism, but ABA can definitely promote their strengths for communication and daily living skills. Reason 7, it will help them how to sleep through nights and definitely use the bathroom with their functional communication and their functional behaviors. Children with autism deserve ABA because it will help their parents be the best parents they can be for them. Children with autism deserve ABA because there's more scientific evidence demonstrating ABA works than there is any other intervention or treatment. And Kelsey is going to talk about the ethical codes for ABA.
Okay, so as we've learned in this class, ABA has a specific set of ethical codes that are super important for us to follow so we can have this field that can be looked in a positive way. So the Behavior Analyst Certification Board has put together a list of ethical codes to be followed at all times while active in the field. All applicants, certificates, and registrants are required to know and follow these ethical codes at all times. This code can ensure that behavior analysts are being ethically responsible throughout every aspect of their work. It can also show the progress in our field, since some individuals compare can compare ABA to old unethical treatments like electric shock treatment and things that happened like 50 years ago. The code is broken down into 10 sections, ensuring behavior analysts fulfill their ethical responsibilities to the clients, their families, colleagues, agencies, and any other individual involved with the given case. As behavior analysts, we strive to comply with these ethical codes, which aren't the same for every field, and other fields may use alternative models, such as the medical model that Ricky is now going to start introducing.
So the medical model by Hansen et al. States that it is one of the oldest models in the field of autism. The overall goal of this model was finding a prevention method and cures for autism. The prevention method and cures for autism consisted of complementary alternative medical treatments. So these can be like dietary approaches, medication, and holistics. We can break the CAM approaches into smaller categories such as medication and alternative methods, like I mentioned. There are medications that can help ASD children who have inattentiveness or seizures. However, as we know, there are no medications that can cure autism or maladaptive behaviors. Hansen et al. Also states that influences of CAM and autism in community society. A survey study was taken from Developmental Center in Boston with children who have a diagnosis of autism, and 74% of these families with children who have autism have used CAMs. Families also mention that the natural approach is kind of the trend and rather an artificial approach. Also, a literature review of the medical model. The different models state that the medical practice for the quality of care for autism relates to the CAM usage among families. The research states that CAMs can be used to alleviate stress from families, especially as time goes on. And I'm sure we see that in our work settings, that there's a lot of stress from the families, and they tend to kind of want to use these models as in kind of cures or things that will help them make progress. There's a lot of different perspectives on why people choose to use alternative medicine to treat autism. According to Hansen, seeking out alternative medicine to help an individual with autism is not enough. They don't have like enough treatment access. There's poor incentive programs provided sometimes at schools, and there's lack of agreement on research on which treatment combination works the best for autistic children. Parent perspectives, there is minimal information regarding why they use particular methods. However, Mindell et al. 2004 discusses the important factors, particular beliefs on etiology of ASD treatments and misinformation that parents receive. Also, Mindell et al. 2004 states that culture is defined as a way of life, values, and beliefs and attitudes which contributes to the CAM usage. Therefore, culture norms will be in the forefront of parents' minds when they're choosing treatment methods for their ASD children. In conclusion, the lack of efficient communication of the current body of research regarding effective treatment of autism is the main problem. The ethical relationship for the medical models rely on a code 2.20 responsibility. As practitioners or anyone that comes in contact with an individual using the medical model treatment, it is beneficial to share current research on ABA versus the medical model, because there's not sufficient research that proves that the medical model is the most effective. Also, evidence-based treatments for medical conditions such as seizure or other information of medical condition affecting the individual from learning is beneficial to talk about, but the medical model alone is not an effective base treatment. And Kelsey will now talk about the sensory integration therapy.
Okay, so sensory integration therapy is another alternative model that is commonly used for children with autism. It attempts to help the children pay attention and learn. It can help hyperactive children feel calmer and hypoactive children feel more alert. Sensory integration therapy was developed in 1972 by A. Jean Aries. She describes it as a neurological process that organizes sensation from one's own body and from the environment and makes it possible to use the body effectively within the environment. It attempts to change how an individual processes and organizes sensory information through using sensory stimulation. These can include activities such as jumping jacks, different swings, bright colors, Play-Doh, yoga poses, and it could be simple as like doing chores. And also commonly people use like massaging and scratching and tickling to use the senses. The goal is to help, if they're trying to work with noise sensitivity, sometimes music will be used if a child has difficulty understanding or using voices. If the child has a tactile sensitivity, they may use like weighted pressure such as pillows, blankets, or hugs. For taste sensitivity, it's not as common, but they'll start trying to introduce like new foods and textures. But usually a lot of sensory integration therapy focuses on non-food related senses. Visual sensitivity, they'll use fidget toys to help a child be able to focus on a given task or something that the child finds mesmerizing in a similar kind of way. There's also smell sensitivities, and certain preferred scents can be used as reinforcement and also to try to increase tolerance towards less preferred smells. So when you're using sensory integration therapy, usually an occupational therapist is the one providing it, and they will create a sensory diet. So a sensory diet is an activity plan that is made up activities that a child can do to improve their senses, their being able to be calm and hyper at like the right times. So the sensory diet is the plan, and the snacks are the activities that make it up. Occupational therapists use these sensory diets to help the children engage at an appropriate level of arousal. And each session of implementing a sensory diet is supposed to take place for about 10 to 15 minutes at a time. And it's said the results are supposed to last for hours after this 10 to 15 minute session. So for an example, if a child seems sluggish or has a very low arousal, they would engage in a sensory diet plan, such as doing 20 jumping jacks, then bouncing on a therapy ball 20 times, and then holding a Zen bug yoga pose for 10 seconds, and then repeating it during that 10 to 15 minute session. And sometimes this can occur 2, 3, 4 times a day for the child. So sensory integration therapy is said to focus on the proximal senses of the body. She wanted to focus on the vestibular, the tactile, and the proprioceptive senses, especially during child development. So the vestibular is made up of the parts of the inner ear and the brain that help control balance and eye movements. Tactile is concerned with touch and the perception of touch, and proprioceptive is the unconscious knowledge and perception of movement and spatial recognition. These senses are theorized to dominate a child's interaction with the world. Focusing on creating a body-centered therapy is supposed to improve these senses, the child's behavior, or his or her interactions with others. Sensory integration therapy focuses on these senses and helping the child increase their understanding and perception of each, hoping to improve their behavior and understanding of themselves and being in their everyday life. So parents, when they were interviewed for this study, what they were hoping to get from sensory integration therapy, and they were hoping that it would help their children build relationships, self-regulate behavior, and have an understanding of themselves. A study was done, and the top 4 reasons that they found when they interviewed parents was self-regulation, interacting with peers, participating in skilled motor activities, and their self-confidence. And culturally, Sue and Parham in 2002 tried to create a questionnaire to look at cultural values and how they've been used in studies of sensory integration therapy. And even though there are many efforts being put to translate the procedures into other languages, it is mostly an American-used therapy practice. So it works with American culture norms. It hasn't really branched out as much to other countries and other cultures. So when testing sensory integration, they use the Sensory Integration and Praxis Test, which is SIPT for short. It was first used in the beginning of the 60s. Jean Aries, who created this field, also created this test to try to find a way to actually test to see if these therapy practices were actually helping. They had issues with really small sample sizes when they first started doing this, and had very questionable reliability, but it was still very widely used in occupational and physical therapy. Once it was seen that the reliability wasn't where she wanted it to be, Jean Aries decided to start developing new methods of testing for sensory integration and began developing what we currently use as the SIPT in the early 1980s. So today it's made up of 17 subtests, and the children attempt to perform certain visual, tactile, kinesthetic, and motor tasks. It's the most complete and flexible assessment that they currently have to measure sensory integration in children, especially with children with autism. It takes 2 hours to administer the test and another 30 to 45 minutes to analyze the results. And training for assessing and giving this exam, it's recommended to go through training, but it's not required to do it. And when it's used correctly, the test has passed reliability and validity tests. And it would be the test used in some of these studies that I'm talking about next. So early in the 80s and 90s, studies were trying to find evidence to support the treatment that had been used for a couple decades already by that time. Majority of the results were unsuccessful in proving any efficacy or effectiveness of sensory integration therapy. And one of the most looked at studies at the time was Mason and Iwata's study in 1990. It compared sensory integration therapy to behavior intervention for individuals with self-injurious behavior. And the self-injurious behaviors were reduced only when the sensory integration therapy was paired with the behavior intervention. It did not have an effect independently. The first of the positive results, which there have been very few actually published, was in 1988 by Dura et al. And it was trying to help an individual with mental retardation, in their quote, struggling with self-injury. That was their title and an abstract of what their goal was trying to do. They used vestibular stimulation, which was pretty much just swinging back and forth. And they had no instances recorded of self-injurious behavior during the sensory integration therapy for this individual child. They compared using behavior interventions with this child, and the sensory integration therapy was more beneficial for treating the self-injurious behaviors that the child had. This was one single case study and did not compare the treatments to a wider population. It does show that there can be some improvement when implementing sensory integration therapy, but much more research would need to be done. And after these early studies, one of the biggest questions that researchers had at this time was, does this sensory integration therapy work for some people, not for others? Or is it something in the way that we're creating our studies? So later, after the turn of the century, Leong and Carter in 2008 published a review of all of the articles that they could find that met the criteria from 1994 to 2007 for sensory integration therapy. And they conducted a systematic analysis of 17 studies that met the requirements. Many of them had weak design and poor methodology, and the higher quality studies had more negative results for sensory integration therapy. So the studies that did show some improvement tended to have weaker designs, methodology, or analyzing techniques. So after they completed this literature review, they recommended that sensory integration therapy be used only in experimental contexts, and it should only be used experimentally until they could find evidence-based research that could show that it was actually being effective. And right at the next year after that, Delvin in 2009 compared sensory integration therapy to behavior intervention 20 years after Mason and Iwata did. And he took four individuals and used alternating treatment of sensory integration and behavior intervention. And all of our 4 participants had 0 or near 0 levels of injurious behavior after receiving behavior intervention, and there was no statistically significant amount of change that occurred after the sensory integration therapy. So it just further had the same results 20 years later. When researching on autism websites for this assignment, I found that there was one article that was posted on a lot of websites that were trying to be very pro sensory integration therapy and try to explain it to parents with autism. So these websites that are most frequently visited by parents, they were linked to a study done by Shaw in 2014. And the study looked at 32 participants and randomly assigned them to a control and experimental group, looking at the effects of sensory integration therapy in occupational therapy. They found that the individuals scored higher after receiving sensory integration than the control group, and also that less assistance was needed in their daily life and in social activities. The reliability of the test was decreased because the client and parents had knowledge of what they were aiming to prove in this study, so there was a little bit of bias there. This is the largest sample size in a study that has had positive results in the effectiveness of sensory integration therapy, and this was in 2014. And even the authors of this study agreed that much more research needed to be done. It didn't mean that this all of a sudden was an evidence-based practice, but it opened the door to trying to see what they did differently and if it would be able to be replicated to larger sample sizes. And so this is also why it's important to be super up to date on the new research in any field or the field that you're commonly, that you work, like when we work with our kids with autism, a lot of them have occupational therapists and a lot of them are doing treatments such as the medical model or sensory integration therapy. And it's important for us to know what's new in even those fields, because I had always been under the impression that there were no positive studies about sensory integration therapy. And if I dug enough, I found one that had enough validity and reliability to be considered positive. So when we're looking at sensory integration therapy, one of the biggest ethical problems is the reliance on scientific knowledge, which according to our ethical code says behavior analysts rely on professionally derived knowledge based on science and behavior analysis when making scientific or professional judgments in human service provision or when engaging in scholarly or professional endeavors. The knowledge behind sensory integration therapy has not been scientifically tested or proven and should not be used by behavior analysts according to our ethical code. And also in 2.09 in treatment efficacy, when it says clients have a right to effective treatment based on research literature and adapted to the individual client. Behavior analysts have an obligation to advocate and educate the client about scientifically supported and most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to clients and society. And again, there is not sufficient evidence for sensory integration therapy, and it would not be ethical to use because it's not an evidence-based treatment. And lastly, if we were looking at a 9.02 of the ethical code, when it looks at the characteristics of responsible research, it breaks down all the specific criteria that should be included when conducting research. The sensory integration therapy studies had some issues with generalization across populations, and as well as the results appearing misleading, especially in the 80s and 90s. The results section of sensory integration therapy shows that a lot of the time, no positive effect can be measured based off of the data for this treatment. Yes, yet this treatment is still widely studied, used, supported, and taught to new therapists. It should be unethical to continue using a treatment program so widely that doesn't provide clear results that it's actually working, and why we as behavioral therapists would not include sensory integration therapy with our normal programs. So we came up with some possible ethical dilemmas. So the first scenario, I'm going to give to Ricky. A family has asked your opinion on the medical model and are thinking about trying some diets and holistic medication to help them participate in therapy and make progress. How you answer this question and guide them in the direction, how would you guide them in the right direction of evidence-based practice treatments?
So based on the information provided for the medical model, you want to definitely provide them with research-based, evidence-based practices on why the medical model isn't the best method to treat them and to help them make progress. However, if they are having some inattentiveness or seizures, something that is medical based, you should refer them to their primary doctor. Also, for speech therapy and occupational therapy, going over behavior therapy as well, how those all together can work as a multidisciplinary team to provide effective treatment methods that will be helpful in all areas. A lot of our kids that we see for autism or that have autism have occupational therapy, speech therapy, and ABA, and we all work together to help them make progress in all areas. And it's definitely eye-opening to the parents to see that not the medication is going to help them improve. Actually, the therapy and the rehab helps them improve in all areas and make them functional communicators of society, functional behavior and behavior change programs, and as well as providing some occupational therapy helps them with some sensory and self-regulation. Scenario 2, I will give to Kelsey. You are working with a client in the home. The client's parents have recently began occupational therapy services as well and are fascinated by his new sensory integration therapy. They want you to incorporate this new sensory diet into your daily session. What is the ethical dilemma and how would you solve it?
So we've had similar ethical questions previously throughout the class, but it's important to point out, especially during an alternative models debate. We, as behavior analysts, we have an ethical code. We are only supposed to be using the programs that are evidence-based and have research and are proven to have a positive impact. And even if the type of program we're using has a history of being positive, if it's not helping that individual child, then it needs to be changed and it needs to be individualized to that child. There's no way for us to know what went into creating the sensory diet. We're not meeting with the occupational therapist right then, and we don't have the training, the research, or the evidence to support why we should be using this program. If I was in this situation, I would try to first talk to the parent and make them, not make them, but talk about why we do use evidence-based programs and why what we're using, like I can show them the data, like this is why this is working. Like this is where your son was 2 months ago and now this was last month and here's where he is currently. We can't always show that with non-evidence-based practices. So to start wrapping up, we came up with some personal experiences that we could relate to this debate, and Ricky's going to go ahead and go first.
So I got my bachelor's in communicative disorders, so I have a background in speech therapy, and then I got my SLPA license from Cal State Northridge. I worked as a speech assistant in the Colton Joint Unified School District and in 2 special education classrooms with visual schedules, sensory center, breakfast club, and a small group circle time. For visual schedules, we definitely had some kids that were in ABA therapy and used visual schedules, a sensory center, breakfast club, and small group circle time. And that was really beneficial for them. And the teachers graphed their data. Speech therapy worked with them on certain targets that we were targeting as far as functional communication. And that really helped the parents see the specific data and the graphs on what their improvement was from ground zero all the way up, from 3 months to 6 months. And then for the whole year when they met for the IEP, it was really cool to see the parents excited for their children on how much improvement they had made on the ABA program as far as the speech therapy program and the occupational therapy program that was all put together. Right now, I am currently a program director for Redlands Community Hospital Outpatient Rehab Program. I'm a SLPA there as well, and I've been there for 3 years. The PEDS population that we do serve, most of them see OT and speech. So with learning about the medical model, the sensory integration, and also all the research that has come from that, I'm currently writing a behavior program for our clinic that I'm excited about with my current BCBA supervisor, because we do not have a specific ABA program right now. However, we want to expand that, and using all these evidence-based treatments will help us really provide the documentation and the graphs and everything that proves why we use the methods that we use and why we don't use certain methods. Kelsey is going to talk about her experience with therapy.
Sorry, I was muted. So when I first started doing ABA, I originally was thinking of going into occupational therapy. So I had been interning at an occupational therapy clinic. Overall, it was a super fun and rewarding experience. It changed my career path because of how little data was taken, and like I couldn't, if my lead therapist couldn't prove to me why it was something that was working and couldn't explain it to me, I didn't feel like it should be something that these kids should be going through 3-4 days a week, constantly coming to a clinic. My therapist often left me alone with the kids. I had no occupational training. Like, I was supposed to just be shadowing. And when I talked to her about when I started behavioral therapy, she had all of these negative comments for me, was trying like, oh, like that's too difficult. I just want to play with the kids is why I'm doing this. And her response of like why she chose it, and just, I know it doesn't represent the entire field, but it was my own one-to-one experience. And it made me take a step back and think, okay, I want to help children with autism, and how can I best do that? Like, what is the best path for me to do? And unfortunately, like as great as the experience was, and I learned so much about sensory integration therapy when I was working with her, it actually ended up making me change my career path in mind. And I ended up starting my master's program a couple months later. So we're going to end with some questions. So the first question we're going to look at is, when would you find it appropriate to recommend alternative models such as the medical model or sensory integration therapy?
So to give a little feedback on that, it only would be appropriate to recommend the medical model if the patient was having like seizures or something that was medically based that you could refer to the doctor. If you're finding that I had, sometimes a couple patients that we weren't sure about the medical condition of something, that would be different than a rehab base, and you would kind of explain why you wouldn't have that in your scope to recommend medications. If they told you about some medications that they were using, you would kind of redirect them back based on the therapy and the plan of care that you've provided that is evidence-based, and that you can't really speak on medications to recommend because you're not their primary doctor. And referring them again back to their doctor would be most appropriate for the medical model.
And for sensory integration therapy, I feel like as a behavior analyst, you would never be recommending it. You wouldn't be implementing it. It was really cool, actually, that I did get to read an article that they're starting to find a pattern that they can find that it does have a positive effect. Like, if there's another way that we can help our clients, then by all means, I'm all for it. But until it has like a strong evidence base and is proven to be reliably effective for the children, I don't feel like it would ever be appropriate to recommend something that you don't know has an effective treatment. Another question was, why are these alternative models so popular?
So feedback on that would be, I think for the medical model, definitely culture plays a huge role in that, and definitely misinformation, not enough information, lack of access to therapy, definitely in a community where culture is huge. They tend to feed off of each other on what they're using or what they think has worked for their kid with autism. And like I said, referring back to the ethical codes and saying to them, here are the evidence-based practices of why you should come to ABA therapy, and just giving them the principles of ABA and explaining in their terms of what ABA is and how it could help their kid with autism would be most beneficial. I feel like I get really good feedback from the clients that I work with and the families when I talk about in their terms of how it could help them be a functional communicator, how it could help them be functional in their daily lives as they grow and have vocational jobs or certain group homes that they might be able to go into. Parents give really good feedback on long-term goals.
And going off of that, I feel like there's also, for so long, there weren't strong evidence-based treatments, especially in the mid 1900s when shock therapy was so popular, and everyone's been looking back and having this negative image of treatments like this. There was no really strong evidence-based treatments. So the fact that like treatments like the medical model and sensory integration didn't involve shocking and directly hurting their patients right then, it's already, at that point in time, I feel like it would have been the best option. But now that, you know, science has grown, we have internet and access to all these articles, everyone else's research, I feel like now we can actually break down what is actually the most beneficial, what is actually the best treatment to use, not just which one is better than the other one. And then, which I think we've pretty much answered, are back to our basic focus question is, which model is the best model based on research and evidence-based practices to address the quality of care for children with autism? ABA therapy. There's not much research and evidence. There's certain individual cases for alternative models, but it's not an overall effective and proven treatment to use. There we go. Thank you guys for tuning in. We're excited to see your guys' responses and spark some discussion about this topic.
And